and get started, just so that we're respectful of people's time. But thank you so much, Lynn, for your efforts, and thank you everyone for heard about a lot in the news. Dr. Sogbetun is an infectious disease physician and a public health leader. She completed her residency training at the Case Western University St. Vincent Hospital in Cleveland. And she went on to complete her infectious disease training at the University of Cincinnati, where her research focused on HIV patient mortality. She has practiced infectious disease in both private practice and academia for many years. And early on in the COVID pandemic, she led efforts against COVID at Janssen Pharmaceuticals, which is now known as Johnson and Johnson. They were one of the earliest producers of the COVID vaccine. She currently works with the research and development section of AstraZeneca and is also a chief physician here with us at DPH. Dr. Sogbetun, the floor is yours.
Can you hear me?
Yes, we can.
Fantastic. Hi, everyone, and thank you for this opportunity, and thank you for taking the time this evening to listen to this rapidly changing and evolving topic. So for disclosures, as Dr. Awe said, currently work at AZ Research and Development, but full disclosure, AstraZeneca does not produce or manufacture any Mpox-related products, whether medicines or vaccines, and the information presented here is without bias or favoritism towards any pharma company or medical device manufacturer. And so content for this activity will be well-balanced, evidence-based, and unbiased. As a brief outline, I'm going to move around a little bit of a unique way of presenting medical topics, just because a lot of concern for Mpox is public health and epidemiology. So I'm going to start with a little bit of that, then go into the disease itself, and then go more into public health again. So just bear with me. Some of the terms in the beginning may not make sense, but it's all going to come together at the end. A few terms I just want to go through briefly. Hold on, let me minimize. Okay, because I was seeing everyone on my screen. So just some regular infectious disease epidemiology terms. An endemic disease is a disease that's consistently present but limited to a particular region. It makes it easy to predict and to monitor, and it's always constant. An outbreak is when you have a sudden rise in cases, usually again over a specific geographic area. Dengue outbreaks occur occasionally in the Central and South American countries, and Mpox is an outbreak. An outbreak usually happens on top of an endemic area, and then it dies down again. An epidemic is an unexpected increase in the number of cases over a large geographical area. For example, you could have a measles epidemic, yellow fever, and the term is now expanded to non-infectious diseases, for example, the obesity epidemic in the US. And a pandemic is an exponential spread of a disease over several countries and populations. And to note, it's not related to disease severity. It could be a minor disease, or it could be a severe disease. As long as it affects several countries and populations, it's a pandemic. And remember the H1N1 influenza, the COVID pandemic, HIV is a pandemic, and we do have a TB pandemic. So talking about Mpox, it's a viral zoonotic infection caused by the monkeypox virus. And it's an orthopox virus, and there are other orthopox viruses. Variola, which we know quite well, which is the causative agent for the smallpox disease. Vaccinia, which is a virus actually used for the smallpox vaccine and the Mpox vaccine. And there are several pox diseases for animals. There's cowpox, there's rabbit pox, there's camel pox. If you notice, the virus is still called monkeypox virus, but the disease is now called Mpox. And this is because in November 2022, the WHO changed the name of the disease to follow best practices of not naming the disease after animals or geographic locations to reduce any stigma that could be associated with the original name. And eventually they will change the name of the virus. So this is why I'm going to start a little bit with this, even though it may be a little bit of early information because we'll come to the disease. But we can't talk about Mpox without talking about clades. And everywhere on the news is what we hear about. So now we know, again, this was more recent, now we know that Mpox has clade 1 and clade 2. Clade 1 has been endemic in the Congo Basin. It has a higher mortality rate and it's spread from animals. Now we have subclades, again, more recent information. And clade 1A is mostly responsible for the Mpox outbreak in Congo that started in 2023, 2024. Again, it's endemic, but this particular outbreak started in November of 2023. And then there's a new clade 1B, which is found in a small area in the Democratic Republic of Congo. Clade 2 is endemic in West Africa. It is less virulent. It has a lower mortality rate. It does spread human to human as opposed to the other that spreads from animals. And clade 2B is the strain that's responsible for the 2022 global Mpox outbreak that is still ongoing in Europe and in the US and really the world over. Looking at the progression of Mpox over time, it was first seen in the 1970s in humans. Again, this is a zoonotic disease, but really few cases. In a 10-year period, there were 59 cases. High mortality, we'll get to the reasons for mortality later. And all cases were linked to exposure to small forest animals. But then as smallpox became eradicated in 1977, the incidence began to rise, still associated with living in forested areas, male sex, and an age less than 15, which again, just all that is associated with encounter with small forest animals in rural areas. In 2003, in the US, we had the first Mpox case, and it was a patient contact with prairie dogs. Now, these prairie dogs had been the prairie dogs acquired the virus from African rodents in Ghana, but it was when the two species were housed together at a distribution center in Illinois. So there were prairie dogs that were housed in a distribution center in Illinois, and there were African rodents from Ghana that were also in the same center in Illinois, and that's when the virus moved from the rodents to the prairie dogs. And so the persons that came in contact with the prairie dogs were the ones who had the Mpox disease in 2003. And currently, transportation, sale, or release into the wild of prairie dogs and animals from Africa has been prohibited by the CDC and FDA. And we have not had any other cases in the US or outbreaks in the US related to imported animals. And between 2018 and 2021 in the US, there were a few travel-related cases from West Africa. But again, these cases contracted the disease in West Africa, specifically Nigeria, and there was no human-to-human transmission in the US. And the clade wasn't known, but at this time, clades were not yet, the genomics was not yet described. And then over time, again, it just kept on increasing slight levels in several African countries. It is endemic. But then in May of 2022 is when we had the global multi-country outbreak. You may also see this described as a clade 2 outbreak. This was first recognized in Europe and then in other countries where it's non-endemic. And if you see what I highlighted in blue, it's important to note that this was in non-endemic countries, which was unusual. It did prove the first occurrence of community spread as opposed to animal spread of the disease previously. And there was a case of Mpox in the UK in a person who had recently traveled to Nigeria, again in May of 2022. So this is really when all of this came up in May 2022. At that time is when genomics was studied, and the clade subdivision was introduced. And that's when we found out that clade 2 was causing the outbreak around the world, in Europe, in the US, and was the same clade, really, in the outbreak in Nigeria years before, but not related to that. Now, that outbreak is still ongoing around the world, but it has significantly diminished. In August of 2022, at the height, this is just US alone, there were about 11,000 cases per month. But currently we have about 250 cases per month, and that has been steady since October of 2023 for the past year. And this is data I got from the CDC this morning. So talking a little bit more about the global multi-country outbreak, the risk factors. This was the outbreak, again, that started in May of 2022 in non-endemic countries. Up to 90%, 86.2% here by this report, were men who had sex with men. And there's a New England Journal of Medicine article that across 16 countries between April and June, where 98% were actually men that had sex with men. The risk factors were high-risk sexual behavior, sex with multiple partners, and this will become more important soon. Multiple or anonymous sexual partners in the previous 2 weeks, attending sex on premises, venues, group sex sessions, or using recreational drugs during sex. This outbreak is highly associated with coexisting HIV infection in as much as 50%, and we'll see why. Because of the transmission, Mpox and HIV share common behavioral risk factors like transmission through sexual contact. And specifically, in addition to HIV, severe disease is seen with a very low CD4 count of less than 200. Another risk factor was lack of prior smallpox vaccination. Now, this is the other clade, which is the one ongoing now, which is all in the news. Remember, the global outbreak is clade 2, and which spreads mostly around men who have sex with men. It peaked in 2022, and it's dying down now, and it has lower mortality. Now, this clade 1 Mpox outbreak, remember, it's endemic in Africa. Now there's an outbreak, an increase. It increased since November 2023. Now, as I'm about to give a few numbers, just a caveat that many of the numbers in this presentation may be different tomorrow. Highlighted in yellow are numbers I calculated, but it's a rapidly changing landscape, and I kept modifying this presentation up till this evening. About a case fatality rate of about 3%, 1.7% in those offered supportive medical care, and it's mostly in children and infants. Started in the Democratic Republic of Congo, has spread to other countries around it. But again, since August of this year, we now have this in non-endemic countries in Africa like Burundi, Rwanda, Kenya, and Uganda, because it was usually endemic to countries in the DRC and the countries around the DRC. It's now spreading to non-endemic countries, and it's mostly clade 1A. Now, the risk factors for mortality in Africa is children, as I had mentioned, pregnant women, immunocompromised, typically uncontrolled HIV. And these are the causes of death. And this is an important public health point that I'm going to bring up later. Is a lot of the causes of death were due to poor infrastructure, poor access to health, and not being able to manage the complications. In fact, the deaths are described as death from the complications of Mpox, very different from Mpox global outbreak in well-resourced countries where the mortality was very, very low. So causes of death in Africa, of course, secondary bacterial infection, widespread skin infection that is not being controlled, pneumonia, malnutrition and dehydration, just simple thing as having the throat ulcers but not being able to get rehydrated, dysphagia, vomiting and diarrhea, and sepsis. Again, secondary infection, bacteremia, encephalitis, you name it. These are the specific causes of death in the outbreak currently in Africa. And as you know, or you may or may not know, on August 14, about a month ago, the WHO declared a public health emergency of international concern. Really what this does, it removes the red tape and allows flow of funds from different countries. And there's very specific criteria for declaring this. It has to be a serious threat, unusual, and risk for international spread. And currently, the Africa CDC is asking for $15 billion and 10 million vaccine doses that will help to mitigate this outbreak, which is a significant ask. An update today actually is that vaccinations in the Democratic Republic of Congo will start October 2, and this will be with vaccines that have been donated from the US and Europe. But on Friday, thankfully, the WHO has now given a pre-qualification to the vaccine. And we'll get to reasons why, because the vaccine, you can't really do a randomized control trial. So there is pre-qualification to the vaccine. Now, even though the Democratic Republic of Congo had approved the vaccines, they don't have the funds to purchase it. You know, approving a vaccine doesn't mean much, really, if you can't purchase it. Now that the WHO has pre-qualified the vaccine, Gavi, which is the Global Vaccine Alliance that funds purchases of vaccines for low-income countries, can now purchase the vaccine from pharmaceutical companies and ship to affected countries. But previously, it was only donated vaccines. So on October 2, they're going to start vaccinating with the donated vaccines. But now that the pre-qualification has been enacted, Gavi can then go directly and get these vaccines to the people on ground. And this is a very important public health and health equity. It's just very different in the way vaccinations function over there. For now, they're targeting healthcare workers and sex workers. And apologies, this isn't in the slide. Again, just a lot of new information as time was really moving rapidly. So there's a very low risk of Clade 1 outbreak in the US. General population is classified as low from the CDC, and for men who have sex with men is classified as low to moderate. And I had mentioned this slide, if you can look at the yellow highlight, this is the part that's important, is the case fatality rate for the Clade 2 Mpox, which is the global outbreak in the Western countries, is 0.22%. It's very low. It's really in immunocompromised persons, as opposed to, you know, about 3 to 4% in the outbreak in Africa. And this shows that as of 2024, 26th May, we had about 7,851 total Mpox cases reported in DRC, including about 384 deaths with a case fatality rate of 4.9. But this is only new cases for this year. I had to do some calculations to try and get some total cases, which I think I have. So this map, this is a map that shows you the confirmed Clade 2 cases since January of this year. Again, you can see it's global, it's in Europe and in the US, and the previous one really shows you the current outbreak. Interestingly, there are only 3 countries that have had both clades: Cameroon, Thailand, and Sweden. And Sweden did report a case in August of Clade 1. This is to show that Clade 1 really is concentrated in the Central African area and does not really spread. And these are the only 3 countries. The ones in Thailand and Sweden are travel related. So I'm going to briefly go through transmission of the disease. And I'll spend time on some slides. Some slides I will move more quickly, and you will get the PDFs later. So this disease is transmitted mostly by direct contact, and that's very important, and we'll see why soon. Infectious sores, scabs, and bodily fluids were very the highest rates of transmission for the 2022 global outbreak. Close sexual contact at that time, very rare household transmission, or living in crowded area or spread in healthcare facilities was really rare. The difference is in this outbreak in Africa, animal exposure is the primary cause of transmission. Now we're beginning to see household transmission, and there's a new Clade 1B, which is spreading amongst women and heterosexual sex workers in specific areas in Democratic Republic of Congo. These other methods of transmission are not very common, but they are common for viruses: indirect contacts with fomites, respiratory secretions, large droplets, again, rare in the global outbreak, perhaps more common in the current outbreak in Africa. We do have vertical transmission in the outbreak in Democratic Republic of Congo, very few cases though, but miscarriage and stillborn, where the babies were born with a rash. For body fluids, Mpox has been identified in semen and other body fluids, but transmission has not been established. It's transmitted by skin to skin contact. Percutaneous spread does happen. It is reported in the US. Again, it's uncommon. So transmission in healthcare facilities is very low in well-resourced countries. It did increase in 2022 due to needle stick injury, but again, just very low in well-resourced countries. For prevention, since I mentioned that, I'm just going to go through prevention and control in healthcare settings. And I do have the numbers for contact here in Delaware, but really immediately notify infection prevention and control personnel if there's any suspicion to have Mpox. And of course, you isolate the patient, use personal protective equipment and standard cleaning and disinfecting procedures, and avoid dusting and vacuuming just because we're still looking at how fomites could spread this disease. So now I'm going backward a little bit, but that really needed to be said first to get an understanding of what's going on right now, and I'll go quickly through the clinical manifestations. It's different in the two diseases. These are the features common to all outbreaks and really common to most viruses. It's a viral exanthem. You have systemic illnesses and you have your characteristic rash, and then you have non-specific lab findings. So this could be many, many diseases, except of course, it has that characteristic rash. So keep that in mind. This does not differ from many other illnesses. There are a few differences, honestly, maybe for academic or surveillance purposes, between the endemic region, Clade 1 outbreak currently going on, and the global outbreak in the past. Fever is lower in the global outbreak. It's more in the endemic Africa outbreak. An important point for us is lymphadenopathy is not very common here in the US with the global outbreak, and many times it's regional. Some people come with a regional lymphadenopathy and pain, as opposed to the generalized lymphadenopathy that we see typically with viral infections. And some patients in well-resourced countries have no systemic symptoms at all. And this is the characteristic rash of really the pox viruses, right? It starts, as a macule, and becomes a papule, or a pustule. It's firm at that end. Then that vesicle that's umbilicated, where it's depressed in the center, and it scabs over. Please note that it's still infectious until the scab has fallen off completely and new skin has formed beneath it. It's still infectious till that time. That's very important to know. The timing is also different between the outbreaks in endemic regions. They develop at the same time. They have the rash, it's the whole body, and it's clear. For the global outbreak and what we're seeing here in the US, the lesions are different areas. And of course, at different stages. And of course, for the location, because the global outbreak is sexual contact, the rash is very much concentrated around the anogenital, the oral and the perioral area, the penile shaft and vulva. While in the endemic regions currently, head, face, and arms usually starts in the center and then spreads out. And also in Africa, you have hundreds of rashes at the same stage, which but quite different in the global outbreak. Again, what we've seen in the US is the global outbreak, but I figured I would give this distinction, even though the risk is low for Clade 1 to come over here, just so that we would know the differences. Now, proctitis is a key feature, really a key feature for the global outbreak that we see here. And the rectal pain, and these really are presenting symptoms in many of the patients. anorectal pain and tenesmus, with or without a rash. And that's important to know because they may not have a rash. Sometimes proctitis alone is the only manifestation that they have. The pain can be so severe that many times hospitalization is for the pain, just to manage the pain. And just an idea that the presentation is similar to other STIs. You can't tell by physical exam the difference, and we'll talk about differential soon. You could also have pharyngitis and tonsillitis, again, due to the sexual contact nature of this disease. There is ocular Mpox, which can cause conjunctivitis and even a loss of vision. And there is encephalitis and encephalomyelitis, sometimes seen in immunocompromised subjects. And just a note, even though the genital lesions are mostly in the global outbreak that we see here and in the Western world, there's a clade 1B that's new in Africa, again, in sex workers, mostly heterosexual, and some genital lesions have been seen, mostly in women. Hospitalization in Africa, it depends on the resources. We don't really have good numbers. It's uncommon in the global outbreak, and it's really pain managed and isolation. Mortality, we had talked about. The risk for severe disease over here in the global outbreak is really immunodeficiency, CD4. I would say maybe even less than 50 in some cases, just because supportive care is the mainstay of treatment. In Africa, it is mostly children, pregnant women, and those who are immunocompromised. And a very low CD4, similar to what you have with herpes and varicella. You can have large necrotizing lesions in AIDS patients that continue to progress, and encephalitis. This is across both outbreaks. And this is because of the immunosuppressed status. So for diagnosis, this is very technical. And that's why I have the information for the Office of Infectious Disease Epidemiology. You call this 302 number, you hit option 6, and you get contacted. You get someone that you talk about case definition, testing, referral, treatment, enrollment in studies, anything of that nature. This is the number to call. The 1888 number is for after hours. So 24 hours a day, you have that access. And there's also an email, dphcall@delaware.com. This is very important. However, in our practice, the suspect case is a new rash, a new characteristic rash. Any rash, that has that umbilicated view could make you suspect, or it meets one of the epidemiological criteria, which I will get to. That's a suspect. The next test is to test. And the probable case means that you have done the test and there's orthopox virus DNA. Now, note this test that is the general test available in labs and public health department is an orthopox virus DNA test. It's not an Mpox test. The confirmed case is the CDC runs that. That's demonstrating the presence of Mpox using a PCR for Mpox. But the probable case and the testing that's done in local labs, public health labs, and the CDC too, is a test for orthopox virus. And that's really all that you need. And again, even once you've reported, the CDC is involved anyway, but it's just they do that confirmation just because they're tracking the disease on a daily basis and all. It's not necessarily, it's more for surveillance. One of the tests for the probable cause, as you can see, is anti-orthopox IgM antibody. Again, it's anti-orthopox, so it's either PCR or is the histochemical testing or the anti-orthopox IgM antibody, and those are orthopox virus tests. Just wanted to make that clear. Only the CDC has the specific monkey right now. This may have changed, so don't hold me to it. The information changes very quickly. This is the EPIC criteria that could make you suspect. Remember, it's a rash, or they have contact with someone who had a similar rash, or they had sexual contact with individuals in a social network experiencing Mpox activity. So just pretty much anything in the history that makes you suspicious. Of course, they traveled outside the US to any of the countries with confirmed cases, or they had contact with a dead or live wild animal that's an African endemic species. Those would also make you suspect. And again, I'm going to share that number in subsequent slides. For travel risk, this is current as of, I want to say Monday, so it may have changed by today. But these are the travel risks for the current outbreak. It's the Democratic Republic of Congo and countries with shared borders. It has spread beyond these countries, but this is where we have travel risk. If anyone is traveled from these countries, they could be, and they have a rash or any of those, pretty much if they travel to these countries and they have a rash, they're a suspect case and you should test. So that's the next step, right? So you suspect, you do the PCR test for orthopox virus DNA. It's your regular viral test. It's the virus is teeming in the lesion. So, you don't have to use a sharp, don't use a sharp to open up to collect samples. It's very high volume. Just swab the lesions and, of course, contact the lab testing facility, call OIDE. Don't just do the test. There's specific instructions that you would have to follow. And you can also do serology, again, under the guidance of the OIDE. And the CDC website has fantastic, really, really good information. For the differential diagnosis, again, this is not very much distinguishable from many other disease. So varicella chickenpox, I put some in bold, smallpox, vaccinia, we do have pox rash from one of the vaccines, which is live, which I'll get to. But the herpes simplex virus, even though the rash is not umbilicated, it's a vesicle. And then STIs, LGV, primary syphilis, chlamydia, gonorrhea, it is very difficult to tell them apart, and you cannot make the distinction by physical exam alone. Impetigo, molluscum contagiosum, and other pox viruses. But the lesson really in this slide is that you cannot tell Mpox by physical exam. You need a very good history. So going a little bit, and please, if there are questions, put them in the chat. Forgot to mention that. Just put the questions in the chat, and we will go through them. And if there are any questions I cannot get to, and I need to do some more research, I'll get that answer specifically back to you. For treatment and prevention, treatment is mostly supportive care, pain relief for the proctitis, NSAIDs, Tylenol, sitz bath. And for presentation, note that the genital and mucosal lesions can have pain out of proportion to their appearance, right? You're wondering, is this why this person is saying that 10/10 pain? But yes, most of the admissions are actually for pain. And again, you treat the secondary bacterial infections because this is really the reason why you have deaths in Africa. This is more specific for us here. A lot of the complications they have in Africa, if someone is not able to eat, they're dehydrated, we're giving them IV fluid. So those, we really have that risk, and that concern is not as much here in the US. And in general, most immunocompetent patients with Mpox have mild disease and they will recover without medical intervention, right? The supportive care is really pain relief. The mortality is rare with the global outbreak, except with the immunocompromised. Now, there is antiviral therapy. There's a drug called tecovirimat. It inhibits a protein in all orthopox viruses. It's available from the CDC under expanded access. Now, a note for us, a lot of technical information, but what we have to think about as medical personnel is there's a clinical trial ongoing right now called STOMP, which patients should be informed about and encouraged to enroll, because we don't have enough trials. And this is a place you can do trials because the mortality is so low, right? So especially for class 2, which is what we have, if they're immunocompromised or high risk for severe disease, anyone with a suspicion should be informed about the STOMP trial. And I did have the number. I will send the number for this trial to you, but CDC have a phone number because they are sponsoring this trial along with the NIAID. I just wanted to add on here that there was a trial, it may still be ongoing, the PALM 0007 for this drug in Democratic Republic of Congo. And the interesting thing is, it was placebo controlled. There was no reduction in the duration of Mpox lesions, but there was a reduced mortality. And this is very important for health equity and access. There was a reduced mortality of 1.7% in those enrolled in the trial versus 3.6 mortality across all of DRC. Now, this is not reduced mortality based on the drug and all. They actually found out that just enrolling in the trial, no matter what arm you were in, got you access to healthcare. So the hospitalization for treatment, just being in the trial increased their supportive care. So those were the ones that their lesions resolved faster in hospitalized patients, irrespective of the arm. So again, reduced mortality for the drug, yes, but a lot of the impact was seen just by enrolling in a trial. And your child has a fever, you're seeing someone in a trial, you're probably going to send for Tylenol, or you need rehydration. You're traveling to the trial site, you're probably reimbursed for the trial. I found this very interesting that just enrolling in a trial helped out that population and their lesions resolve faster, irrespective of the arm. Just wanted to share that. In the US, who to treat, again, this is a CDC and public health decision, but guidelines say highly immunocompromised patients with HIV of CD4 less than 50. Again, even though the drug is safe, the mortality is really low. There's some other options, not recommended. I think we're familiar with cidofovir, which is an antiviral with really bad adverse events, renal failure, liver abnormalities, and brings cidofovir a little bit better, but again, really poor risk benefit for a disease of such low mortality. Others, if you see ocular Mpox, this was seen in Europe, trifluridine eye drops can help. Now, for prevention, and I'm going to round up with quite a few points for public health. We had talked about in the healthcare setting, we identify, isolate, and report, and we use PPE. For a community setting, supportive care at home is actually recommended. Like, don't go to the healthcare facility unless you need to. No access to animals, so it's not spread through that way. You mask, and just don't share utensils in the house. In the 2022 outbreak, counseling, just reduce counseling and behavior change. The MSM population in Europe, in one of the countries, reduced their number of sexual partners by 50%, just by behavioral change alone. And that led to a significant decline in that country. So just that could impact preventing further spread. For vaccination, we do have 2 vaccines. And I had mentioned that we have a live non-replicating vaccine, and this is the one that's well known, the one that we hear about. It's called Genius in the US, and Imvamune in Canada, in Vain in the EU. It's 2 doses, 4 weeks apart. It's effective, and it's the recommended routine vaccine for people at high risk for Mpox. It's given subcutaneously, but interestingly, it's recently been found that intradermally, you can use 1/5 of the subcutaneous dose, and that's what they're going to do in Africa, and that's going to increase the amount of the vaccine by ×5 by giving it intradermally. No data on COAD, but it should be safe, and there's an EUA for pediatric patient subjects, but it's approved for more than 18 years. And there's another vaccine, it's a live replicating smallpox vaccine. There's more adverse events, so it's used only in select patients. Again, not that relevant here because the risk for mortality is so low, so you wouldn't want to use this for the risk-benefit ratio. Just a quick note on the vaccine, if it works. Again, you can do a trial. So they did a case control study. It was a really good one. And it showed, it had an adjusted vaccine efficacy of 66%. But remember, this is case control. So all they could say is patients with Mpox were less likely to have received the vaccine than controls, right? But they did do the control. The controls were HIV positive people, which was, I feel that was pretty good. But that's the best you can do is people have been vaccinated, and then you go and then you look at the cases who got Mpox, who didn't, and then look back, and it showed an adjusted vaccine efficacy of about 66% for 2 doses and about 35% for 1 dose. We also have passive immunization. It is reserved for those who cannot get vaccines, very immunocompromised who will not mount a response, infants with exposure history, and yeah, that's pretty much those 2, available only through the CDC. Just a couple of slides on pre-exposure prophylaxis. You have to call the OIDE for this. This guideline changes very regularly. Currently, it's for men who have sex with men or known exposure to someone with Mpox, but it is on a case-by-case basis because, again, most cases recover. There's some talk about using it in travelers at increased risk of Mpox who are planning to travel to specific countries. But even though this list is here, you may not get it even if you fit this list. Again, low mortality. For healthcare workers, research lab personnel who directly handle cultures for Mpox, right? And again, the OIDE is probably going to have to reach out to the CDC for this, because even if you're a health worker and you deal with hematology or urine testing for someone with confirmed Mpox infection, you don't qualify. You have to be working on the cultures or the animals. So again, not very much needed at this point. Post-exposure prophylaxis, again, it's the vaccine is available for that, but it's under the emergency use authorization for kids and infants, and you have to contact your, I know I've said this many times, your local health department or the CDC. So I want to spend a couple of minutes on the public health concerns and the health equity concerns. Now, a lot of this is just based on my experience as a public health expert and health equity expert in infectious disease, epidemiology, biostatistics, and really looking at this disease and how what does it mean for us here in the US, and what are lessons to be learned, and what should we look out for. I had mentioned that it looks like other STIs, right? So we need a comprehensive travel, social, and sexual history, right? No matter how difficult that is to do, we need to obtain complete STI testing of all the other STIs, including Mpox, and a complete genital and rectal exam. So be highly suspicious of rectal pain, abdominal or groin pain, and mouth ulcers. And it's any hint of suspicion, called the Office of Infectious Disease Epidemiology for Delaware. There's a low risk of clade 1 in the US, and the CDC released this, and that's because of increased access to improved sanitation and healthcare, and really we don't have the zoonotic reservoirs of the disease. So it's not living in the animals there. And so those are really the 2 main reasons. We have really high quality supportive care, access to medical measures, and we don't have the reservoir. So low risk. For men who have sex with men, it's a low to moderate risk. And again, this is of clade 1 because we have clade 2. So we're talking about risk of clade 1 coming into the US is low to moderate for men who have sex with men. CDC says they could be at increased risk. This is through modeling, right? They're doing a best guess. It could change. They do these models to see what could happen if the disease does come to the US. So low to moderate for this population. Now, the good news is, so that's good news. Another good news is those who have already had Mpox or who have received both doses of the vaccine are likely to be protected against both clades, irrespective of which clade that you had. So if you've had clade 2, which is the one ongoing here, you're very likely to be protected against clade 1. Doesn't mean you won't have it, but it's a reduced disease severity, progression, and duration. So that's just something to think about based on public health. For health equity, now, this is why we're here, right? So we know the definition of health equity, a state where everyone has a fair and just opportunity to attain their highest level of health. And these factors, I move to the next slide. So don't worry, I'm going to talk about them. So these are the factors that affect health equity. There are a lot more, right? But these are the ones that I just pulled in that could have an impact in the way that we address Mpox in the US currently, or if a Clade 1 outbreak does come in. We have the social determinants of health and the social and community context, which is really where people live, where they work, their age, their demographics, what kind of discrimination could come into that social community. We have the healthcare access and use, which socioeconomic status is really a big one. But you could also have geography, I think, in some parts of the US. The neighborhood and the physical environment and the workplace conditions, a little bit similar. A lot of that really does tie into social determinants of health, but something as simple as low socioeconomic status, limited or no health insurance could make a significant impact. And then education and income and wealth gaps really go together. The low literacy, you probably have a lower paying job, you're probably more low income, and your access to transportation is inhibited. And we pretty much know how this affects many diseases. And I was trying to think of how this could affect Mpox. There's not much out there on health equity and Mpox in the US. But so our goal is to reduce the Mpox risk in all communities, right? So knowledge gaps, it's a big thing, both for healthcare providers and for patients, right? For healthcare providers, we need to know the treatment options. We need to refer patients to the STOMP trial, right? Do we know about the STOMP trial? Do we have the number for the local health department and speed dial, right? Are we doing a rectal and genital exam? Do we have a bias against certain populations, men who have sex with men? Are we willing to get a sexual history? And for the patient, is there a trusted relationship with the healthcare provider? Are they going to allow you to do the genital and rectal exam, right? Do they even have health insurance or a PCP? And where do they get their information from? Another point is healthcare access, right? So, we know what the data has been on neighborhoods and distance from healthcare facilities or distance from the right healthcare facilities. But even cultural and language barriers, refugees, right? Are you able to communicate? Are they going to tell you that they have a genital region or they're having rectal plane? And workplace conditions. Is every healthcare center in the US equally equipped with PPE? Or are there some places that have more PPE than others? And again, the social and community context sort of ties it all together, where that stigma associated with STIs, right, is both for the patient, for the healthcare worker, even stigma associated with skin diseases. You're seen as dirty, right? There's something wrong with your skin. How long before you come up with that complaint? And in general, the discrimination and bias is something we have to think about. It's low mortality now, but if the mortality does increase and we do get Clade 1, these are some things we have to think about in our day-to-day contact, both for ourselves as healthcare providers and for the patients. That's pretty much what I have. I hope we have some time for questions, and I put this as the last slide in case you missed any of that information for the Office of Infectious Disease Epidemiology. This is very helpful. They have an email, they have a phone, and this should be any suspicion, they really should be contacted and they will guide you. And I'm happy to take any questions at this time or take them down and send you the answers later.
So I see Dr. Ollie has questions in the chat box.
Oh, okay. Let me take a look. Give me a second. Okay, I'm going to read out the question. What is driving the significant rises in 2022 now with this current outbreak? Is it changes in the virus that makes more transmissible or something else? This is a fantastic question. I actually had a slide that was talking about areas that need more research. There's lists and lists of areas that need more research, but it's not very clear what is driving the increase at this time. For the one in 2022, it was the initial cases. So the Clade 2 back in from 2017 to 2018, there was a Clade 2 outbreak in Nigeria, very few cases. At that time, it was well, presumably clade 2 we know now. It was human to human. It was controlled and it ended. So at that time, it wasn't clear that it was different clade from the one in Africa, but it was a human to human transmission. And so someone with clade 2, this is all retrospective, went to Europe. And because it is a human to human sexual contact disease, that's what caused that spread. And then the virus began to spread human to human with sexual contact in those sex parties and sex venues. So that was the driver in 2022, because that was the nature of that clade. But that research was done at that time to detect that it was a different clade from the endemic. Previously, no one knew that it was different, but then it was discovered it was different. So and then the practices, the changes in the practices is really what has helped it to trend down. And more research is needed to define more of why it's gone down. But the mortality is really because the disease itself, the complications are what kill you. So that's pretty much easy to explain with the mortality. But it was human to human as opposed to animal. The more difficult question is the current outbreak that started in November of 2023. This disease has been endemic for years. Now, there's a few things. They've talked about the lack of the smallpox virus, but it's been eradicated since 1977. So why suddenly in 2023? I suspect it has something to do with the 2022 clade 2. I'm not sure how, but it is the same strain. It's the same clade 1A that's been endemic in DRC. However, remember that it was in 2023 that for the one in DRC that they did the genomics. Nobody did genomics on this disease for decades. So we don't know if all these clades we're talking about now are different from the previous clades that we had before 2022. It was just Mpox. Because it was circulating in a specific area, there was no genomics being done. So it could be a different strain. It could be that there are more clades, and these clades are very different from the other ones. Lots of research is still needed. I hope sorry, I know there's lots of unanswered questions, but let's see.
Yeah, that is very helpful. Thank you.
Sure. I've wondered why it took so long to get vaccination program going, as this has been ongoing for quite a while. Unlike with earlier outbreaks, we have decent vaccines. Well, one of the reasons is the suspected case and a confirmed case. They're very different numbers. I put those numbers in and I took it out because they were very conflicting. The mortality is very different if you look at suspected cases versus confirmed cases, right? For confirmed cases, the mortality in some places in Africa in this outbreak is as low as 2%. Some places 1.7%, some places 1%. So if it's a 1% mortality, right, it's still significant and all, but if you look at suspected cases, it's bigger. So it took until that PHEIC was announced. That really is what triggers a global input. In DRC, there's an article I saw that said 29.5 million people in DRC live under war conditions or war-like, just horrible conditions related to wars. So for the country alone to really take on a vaccination program is unlikely. So it really was that public health epidemic of interest and concern that was announced in August 14th. That's what's now making the rest of the world to donate vaccines. WHO has now removed Gavi can act. But again, really what's killing people there is the lack of supportive care. It's so clear, really. But yeah, again, a lot of this is my opinion because there's not very much scientific information out there. I'm curious about rates of Mpox in persons who were vaccinated against smallpox, which was ongoing. And in the US, yes, it hasn't been studied, but there's case reports that show that it is either lower or attenuated. In fact, it's not in the US, but in Europe. So when it spread in Europe, because you do have men who have sex with men who are of different ages, and they did find out that those who had been vaccinated either didn't get it or they were asymptomatic, they didn't have the severe disease. And just a quick point is you can have asymptomatic Mpox in the class 2, the outbreak here in the West, and it's been detected in semen just because someone was doing a study and decided to check 200 men to see if they have it. It was in their semen and they had no symptoms. But yes, this population remains protected. Yes, I don't have the numbers off the top of my head, but yes, they do. Yeah. And in Africa too, the vaccinated population in Africa, the numbers are also much lower for anyone in Africa who receives smallpox vaccine. Yes.
All right. Well, thank you so much, Dr. Sogbetun. This was an excellent, excellent presentation. I learned so much. I'm sure that you're going to share your slides. We are at 7:02. So if anyone has further questions, I would say email to Lynn or to, Lynn, would that be a good way to send questions?
Absolutely, certainly.
Okay.
Absolutely. Email the Medical Society of Delaware and myself, or Anja. We're both in, but have been sending out information to attendees, and Anja will be sending out an email tomorrow with the slides, and we can, if you have any questions, feel free to respond with your question, and we'll make sure that we get that over to Dr. Sogbetun. Thank you.
Yeah, thank you so much again. This was excellent. Thank you.
Thank you. Mm-hmm.
And have a good evening, everyone.
Thank you, everyone.